Afternoon, everybody. We're going to start soon. It's 2:00. My name is Michelle Arnaud. I am the Vice President of Gray Panthers. While we're waiting, I think everyone should wish Jack Kupferman, the President of the Gray Panthers, happy birthday. So please put your good wishes for Jack in the chat.
Oh, sweet.
We're going to let him have a day of leisure, which is well deserved. After, maybe many of you have seen recently, Jack was in the New York Times. So he's been very busy. So we'll wait a minute or two since we had really record registration. So please do wish Jack happy birthday.
How sweet.
Since we're all here to celebrate getting older, which is really a privilege. So, as I said, we've had record registration today. Let's see. Jack, you have a lot of good wishes in the chat, so please keep your eye on it.
Let me
Happy birthday, Jack.
Thank you, loves. Thank you very much. Let me go to.
Maybe we should sing.
Oh, no. Oh, no.
Oh, come on, Jack.
I remember when I used to be a waiter and you'd have to go over to every table to sing happy birthday. I would run the other direction.
Well, you wouldn't have to sing this time. It's just us singing to you.
Yes, we can do that.
Happy birthday to you. Happy birthday.
Can you change
to
it to you?
Happy birthday,
dear Jack. Happy birthday to you. Yay!
I always say you haven't celebrated a birthday unless you've had a Zoom birthday song.
Thank you, my loves. Thank you, everyone.
That's
How
true.
sweet of you. Very, very sweet. Very.
Good.
And Jack, we love you. So
It
happy
works
birthday.
both ways. I love everybody here.
So, all right, we have another minute, but I just want to tell those who just arrived that today we're celebrating Jack Kupferman's birthday. So put your good wishes in the chat. And we're just about to start. So welcoming everyone again. My name is Michelle Arnaud, and I'm the Vice President of Gray Panthers NYC. It's my great pleasure and honor to take Jack's place today and to see all of you here. As I said earlier, we've had record registration. This is our 20th Transformation Tuesday. Jack, can you believe it?
No.
It was June of 2021 that I discussed and proposed to Jack that we launch a series following the success of our documentary honoring nursing home lives lost. Jack, remember how much fun we had putting the documentary together? Anyway, thanks to everybody who's here today that we built this space to address issues that impact all of us in the effort to institute positive change in nursing homes. Gray Panthers NYC is committed to continuing the series until we see the positive change we've been speaking about. And all of us will be here to hold everyone accountable. You can find the recordings of all our programs on the YouTube channel on our beautiful Gray Panthers NYC website, thanks to the wonderful Emily Trask. We convene the last Tuesday of the month, so please circle March 28th at 2 p.m. for the next month's Transformation Tuesday. And just to go back, I want to express how grateful we are to Emily Trask. for bringing together today's expert speakers, Irving Stackpole and Dr. Michael Wasserman, who are going to address a pressing topic: the fragile future for aging services, the collision of money, politics, and denial. An experienced healthcare professional, Irving Stackpole has held many leadership positions and has managed engagements with hundreds of consulting clients on 5 continents as president of Stackpole and Associates, Inc., a strategy, marketing, and research firm founded in 1991. Irving is widely published and quoted, including in the Financial Times, the New York Times, Forbes, and other media. And he's currently going to be speaking to us from Lisbon. Dr. Michael Wasserman is a geriatrician who has been a tireless advocate for vulnerable older adults during the COVID-19 pandemic. Dr. Wasserman served as a member of the National Academy of Sciences, a framework for equitable allocation of vaccine for the novel coronavirus committee. He's editor-in-chief of Springer's upcoming textbook, Geriatric Medicine, a Person-Centered Evidence-Based Approach. He previously served as chief executive officer, overseeing the largest nursing home chain in California, which is where he is located. Prior to that, he was executive director, Care Continuum, for California's Medicare Contracted Quality Improvement Program. Please type your questions in the chat, and Emily and I will do our best to answer after the presentations. And now it's my pleasure to pass the mic to Dr. Wasserman.
Thank you, Michelle. It's an honor. Tomorrow is the 3-year anniversary from when I read about Kirkland, Washington, and put out my first tweet regarding the pandemic. And I'm going to try to narrow my focus for this group, but I really want to answer questions and get all of you involved here, because I can talk on this topic probably all day long. But a little background. I'm a physician. I've cared for folks in nursing homes my whole career. I've also run a nursing home chain. I've also worked with CMS and the quality improvement organizations. And the moment I read about Kirkland, the bells went off. And the bells went off because of the collision of money, politics, and denial. 6 months before COVID hit, CMS had changed skilled nursing reimbursement to a program called the patient-driven payment model, which actually encouraged nursing homes to bring in the sickest people they could bring in, because that would bring them more revenue. And I hate to say this, but one of the things that struck me at the beginning of March of 2020 was that the greatest reimbursement would occur in the first 2 weeks of those stays. And if people came in with COVID and then died 2 weeks later and were replaced by more people, that would be financially beneficial. You might get some idea why I completely freaked out at that time. I was quoted pretty widely criticizing Governor Cuomo as well as Governor Newsom in California, because both states wanted to offload hospitals, which is again a financial thing. Hospitals want to move people into skilled nursing facilities so they can create more beds. So there's just a lot of things around the money. But I think the other thing, and I actually attempted to get some op-eds published in the first weeks of the pandemic, and no one would publish them, about the intersection of real estate and related parties in the nursing home industry. And there's a lot of noise around that right now. You'll see ACA saying that, well, it's only 5% private equity and 12% REITs, but it really is about ownership. And there's a lot of private capital and funding that is obscured. We don't see where a lot of that money goes to. So picture this, and first of all, I want to take one step back. I wrote an article last year delineating what I consider the nursing home profession from the nursing home industry. And I'm sure all of you have encountered less than stellar folks in nursing homes. But in my 30 years, I can tell you that I have had the great fortune of meeting a lot of incredible people who work within the walls of nursing homes, who care deeply for the residents. And I've had many experiences with those residents and showing how much they care for the very staff that care for them. And it's unfortunate that with the intersection of money and politics, that these folks are put under tremendous pressure. Their facilities are understaffed, but the people who work there are trying their best, which is not going to be good enough when you're understaffed. So, you know, I think one of the points I really try to make is, where does the money go? So the vast majority of people in nursing homes are getting paid for by either Medicare or Medicaid. And if we can picture where every dollar that comes into a nursing facility ends up, we'll find that those dollars end up in real estate, they end up in staffing agencies, they end up in other related party services. And one of the things we are really working hard at the national level, I know New York has done this, and I think that recent article by Jordan Rao shows how much transparency is there to be found if we search for it, that we really understand where the money is ending up. Because if we throw more money at a system that is not putting that money into care, shame on us. And I think, you know, we can discuss how much money the system needs, but I think we really need to discuss where the money ends up and whether it's going towards the care of the residents. So on that note, CMS recently put out a proposed rule because CMS, believe it or not, and if you want a line on your advocacy efforts, you may reach out to your senators or your congresspeople, because 12 years ago, CMS actually put into law, or no, excuse me, the government put into law, the legislature, the president signed, part of the Affordable Care Act actually required transparency of nursing home ownership. That law never got implemented. And you may ask why? Well, lobbying and politics is how some of these things don't happen. And so this administration is endeavoring to implement that law. Unfortunately, the proposed rule that's out there right now isn't enough. It really doesn't get us to the bottom of where the money's going. So a lot of us are making efforts to put that pressure on. And I think if there's something you can do from an advocacy effort, let your senators and congresspeople know that this proposed rule is not enough. It's really not going to get us the type of transparency that it's going to allow us to fully, as I like to say, take the emperor's clothes off. We really need to see where the money's going so we can do a better job of figuring out how to change the system. And I appreciate your Transformation Tuesdays. There's so many things we can do to transform long-term care, with a caveat. I am of the firm belief that if we don't bring transparency, nothing else we do is going to work. And it makes sense, because if the money is literally siphoned away, how are we going to have the money to do the things you're talking about? So I really have made transparency the first and foremost item that we need to do. There are other items that might take legislation, and that might be problematic, as we might imagine in Congress right now. So I think shining the light is probably the most important thing we can do. States are working for things like staffing requirements and such. Happy to discuss those things as well. But the last thing I want to mention, a lot of us are upset over what we've seen happen, not only in the last 3 years, but in the last 30 years. And I think there's a natural instinct to want to strike back. There's a natural instinct to want to think that a lot of these things are illegal. Here's the challenge. And Don Berwick wrote a recent article about greed in healthcare, and it really is pertinent to the nursing home industry and all senior housing, assisted livings, et cetera. To me, long-term care right now is about real estate. I actually saw someone tweet recently, what is the similarity between McDonald's and nursing homes? And McDonald's is actually a real estate company. They own the real estate, and the franchises they let, separate people own, but it's really all about real estate. And so it is really important that we hone in on that with the caveat. If you're a REIT, or you're a private equity company, or you're a publicly traded nursing home chain, and you're the CEO or you're on the board, you have a fiduciary responsibility to make profit for your shareholders. I would argue that your moral and ethical responsibility to the residents is a different question that we really need to come to grips with. And I think for the long term, if we are going to impact this industry, I think we just have to be honest about the systems that are in place and find ways of approaching them. And I think I'm going to swing back again. To me, the only thing we can really do right now is start with transparency. If the public can see where those dollars coming into the facility end up, and they can see that it's not ending up in patient care, and they can see the harm done in some of the worst offenders, then we have an opportunity to bring public opinion. And that's one thing that this field has been lacking, that I think if there's a silver lining of the pandemic, with over 200,000 nursing home residents who have died from COVID, is public opinion really wasn't there for nursing home residents prior to the pandemic. And I think there are myriad opportunities for us to harness public opinion, to enhance public opinion, because at the end of the day, the government the political folks don't tend to do things unless there's public opinion behind it. And so I think we really have an opportunity to do this. And with that, I think Irving and I know Irving's going to speak, and we really want to hear your voices and get your questions. This is a great group. As I was telling Michelle before, I followed you for the last few years and really appreciate everything you do. You are trying to mobilize public opinion. So thank you. And Irving, on to you.
Wow, tough act to follow. So thank you, Michael. And I wanted to thank Gray Panthers for having me here, Emily for suggesting it, being persistent. And the topic is compelling, not the least of which because many of the people, as I look around the Hollywood squares, many of the people like me are close to being consumers if we aren't already consumers. So the topic, money, politics, and denial, were the three dominant themes that sprang to mind when Emily pressed for a title some weeks ago. Money, because if you want to understand where somebody's priorities are, you look to see where they spend money. The same is true for an organization as for an individual. And the United States spends less than half. So there's a group of developed economies called the Organization of Economic Advanced States, the OECD. And these 16 rich countries pooled information. And the United States spends less than half of the OECD average on long-term care. Less than half. Now, does that mean that our persons of age are less sick than anyone else? No. Are they healthier than all of these other developed economies? No. We just spend less. We've squeezed and squeezed and squeezed the economic model to support the care of persons with chronic diseases, with ongoing care needs. We've squeezed the system so tight that we spend 46% is the exact number of the OECD average on long-term care. Now that, despite the fact that the United States spends 240%, 240% of the OECD average on healthcare overall. So let me give you the money facts. The United States spends less than half of everybody else on long-term care, but almost 2.5 times everybody else on healthcare. So from a money point of view, it's not at all surprising that the system that delivers care, if you could even say it's a system, there are some people that suggest we don't really have a system in the United States, but the system started at cheap. That's where it starts from the money point of view. Now, as a result of the infection, the contagion associated with the COVID-19 novel coronavirus pandemic, hundreds of thousands of individuals lost their lives in congregate care centers around the United States. Eminently predictable because, as Michael pointed out, these are legacy buildings constructed primarily during the Hill-Burton period in the United States from 1968 or so to 1980. There have been precious few, or 85, there have been precious few new nursing centers built in the United States since 1991 because the government has restricted permits for building because the government thinks that more nursing homes means more elderly persons in those nursing homes consuming government funds. So if that isn't the model of cheap, I don't know what is. To heck with anybody that might need it. We don't even want to build it. So the people stay wherever they are, wherever they can hide themselves away or wherever their relatives can take care of them. We just hide them away. That's the denial part. So we talked about money. We spend less than half on long-term care. We spend 2.5 times on healthcare, hospitals primarily. And hospitals every year kill, not like people die in hospitals. A lot more people die in hospitals than die in nursing care. So in the United States, virtually every year, 250 to 350,000 people die from the care they receive in the hospital. Every year. And nobody says a word about that. You hardly ever hear about it. The technical term is iatrogenic death. That's death as the result of the treatment. So hospitals are killing as many people as died in nursing centers during the pandemic, this horrible epidemic that we've just had, pandemic. But every year hospitals kill that many just because of the way they treat people. So the United States in the money situation with regards to healthcare It's truly, truly dystopian. It's bizarre. And unfortunately, that bizarro fiscal financial model is baked into many of our pension schemes. That financial model, those investments in the pharmaceutical companies, the investments in the real estate companies, the investments in the hospital chains, these are all equity or bond investments that are baked into the very financial fabric of these United States. So changing it is truly complicated. Now, it's not impossible, but it's complex. But the bottom line is that we spend far less on long-term care than anybody else. We spend far more on healthcare, non-long-term care related healthcare than anybody else. And for that 246% more on healthcare, we get absolutely awful results. We have the lowest life expectancy. Our per capita GDP spend on healthcare, as I've already talked about, is two and a half times. It's almost twice as high as the next closest country. And our life expectancy and many, many indicators, not to mention many healthcare morbidity, mortality indicators stink. They absolutely stink. So healthcare in the United States is a bad deal for the taxpayer. It's just a bad deal. We get lousy results. Now, I don't even want to talk about maternal child health, because this year, a Black boy born in Mozambique has a longer life expectancy than a Black boy born in Mississippi. Now, anybody that isn't uncomfortable with that, I question their humanity. But that's what we get out of our healthcare system. That's what we get from the money that we spend in the healthcare system. The politics of healthcare is very clear. The politics of healthcare, Mike already alluded to it. It's driven by lobbying. It's driven by capitalist interests. That's what we have. We have a capitalist system in the United States. And those money interests, when you look at healthcare, healthcare is the second largest lobby in the United States. Healthcare, let me repeat that. Healthcare is the second largest lobby in the United States. The only one that spends more is Mark. Mark Zuckerberg outspends everybody, but the healthcare lobby in the United States is huge. I know because part of my career at one point, I were one. So let's talk about denial, because denial is the underlying glue that holds this horrible mess together. And the denial is built into the fabric of our culture. The denial of age and dependency. We're culturally opposed to dependency. The pioneering spirit, that metaphor of independence, John Wayne, if you will, and I'm sorry to use totally masculine images, but I can't think of a female iteration of John Wayne, but somebody will. And that metaphor drives our treatment of persons with age. I've had the blessing and the opportunity to work all over the world. There is no place, with the possible exception of the United Kingdom, from which we descended or ascended. There is no place on the planet that treats persons of age the way we do in the United States. Nowhere. So the denial is in our dependency and ultimate demise. That's where the denial comes from. We have an octogenarian president, for heaven's sakes. And the polls suggest that his popularity is vulnerable, not because of his competency, not because of his ability to make points or to manipulate audiences, as he so eminently displayed his capability to do at the State of the Union address. None of that has any relevance more so than his mere age. That simply doesn't happen anywhere else. So money, politics, and denial. And anybody wants any further cheering up, I'm available by email or by WhatsApp. I'm going to stop there and see what questions get fielded.
Wow. Well, thank you for those frightening words. Let's go back to some questions. Melody Taylor Stark has a question. Did the CARES money ever reach the SNFs? If it did, is there an accounting of how it was used?
So
Irving? Oh, go ahead.
I'll let Irving as well. I'm sure it actually did get to some of the nursing homes. We will only know when they do a full accounting on how much of that money ended up in resident care. And I don't think we've seen that yet.
To answer the specific question, the money got there, but no, there won't be any accounting. It's simply not possible to account for that much money in the kind of level of detail that we're accustomed to or that we should have. And it should be remembered that at the time, money was being shoveled into the economy like coal into a furnace of a locomotive going uphill, trying to cross one of those mountain ranges in California. So money was being shoveled into the system, and it worked. It worked. So that's what I've seen.
Jack, did you want to say something?
Yes, please. I have a question for the two of you guys. From your experience or from your dreams, what are potential solutions, whether it's about increasing transparency and improving the quality of care and the quality of life? What are specific, concrete possible?
Action.
Yeah, not actions, but
Oh,
solutions.
steps. Okay.
You want to go first, Irving?
Sure. Thanks, Jack. It's a really good question. Michael and I have talked about this extensively, written about it extensively. I would boil it down to 5 things. I'm sorry, there are 5. It should be 2 or 3, and that would be cute, and that would be a soundbite. But we're not talking about cute here, and we're not talking about sound bites. The first thing is that you mentioned quality of life. In all of the work that CMS does to track this sector, and it is an economic sector, there's no qualitative measure of whether or not families or the consumers themselves are satisfied that they qualitatively perceive the services being provided as adequate, fit for purpose, or meeting their needs. There's nothing. So that would be almost the number one thing that I would do, is I would institute in hospitals and with doctors, we have something called HCAHPS. We need something like that in skilled nursing that evaluates quality. The second thing I would do is I would go in and I would reset a number of the current systems measures of outcomes, because they're some of them are extraordinarily clever, but especially in home healthcare, but they're too complicated and they're too administratively burdensome upon the providers attempting to deliver the service. The third thing I would do is I would absolutely do what Japan did 12 years ago. I would institute a federally funded long-term care insurance scheme that would provide long-term care insurance, not for the 11, 10, or 9% of the population, which is about its penetration now, that can afford it or know about it or know enough to even go looking for it. But I would institute a scheme that provided long-term care insurance for persons who qualify. And I would fund that through a small tax on Medicare benefits. There's a significant portion of the population that receives benefits from Medicare who could afford to have a progressive payment for a long-term care safety net across the population. So those are three things that I would do right away. And I don't want to go on too far. Mike, what are your thoughts?
Well, I put in the chat an article I wrote, almost a decade ago. The federal government spends well over $10 billion a year from the Medicare Trust Fund teaching physicians how not to take care of Medicare patients. Just get your head around that. And we've done nothing to expand. In fact, 20 years ago or 25 years ago, the number of board certified geriatricians in this country was 14,000. Today, we have fewer than 3,000 full-time practicing board certified geriatricians. Why does that matter? Physicians like myself stop more medications than we start. We think about what is the right thing to do. We think about quality of life and function, all the things that Irving mentioned. And yet, the number of us who are around is dwindling rapidly. We are just this close to extinction. And my concern is a lot of what we're trying to control. So I'm sure we could talk all day long about antipsychotic medications, but if physicians actually understood older adults and antipsychotics, this wouldn't be a problem. So do we really want to try to legislate around all the things we've screwed up on already by not training the workforce in geriatrics? I'm big into root cause. To me, the biggest root cause is we have not, what I like to call, geriatricized the entire healthcare workforce. The entire workforce needs to understand geriatrics. And if we don't do that, now, by the way, here's the problem. If we could geriatricize the entire healthcare workforce, we would reduce Medicare expenditures by 30%. It's $300 billion. But the healthcare industrial complex, what that would mean is they just lost $300 billion in revenue. Do you think any of their lobbyists are going to support that? So I agree with all the stuff that Irving said, but I always like to point out that if we don't train healthcare people in geriatrics, I think we will also fail. So transparency, geriatrics training, the other things Irving said.
Thanks. Marjorie Logman, I know you have your hand up, but first, our fantastic volunteer, Rachel Bennett, who's also the founder of the Nursing Home Card Project, is going to tell you about a letter that she's working on that we are going to send to everybody on this call. So Rachel, would you like to explain? Rachel, you're muted. Okay.
Yes, thank you, Michelle. Hi, everybody. Irving and Michael, thank you so very much for coming on board today. We're learning a lot from both of you. I wrote a letter because I've been to several Transformation Tuesdays and we learn so much from all of these amazing speakers. And then ultimately it comes down to what do we do? And, there's a lot we could do, but one of the most tangible, feasible, and hopefully optimistic things we can do is consistently reach out to our senators, both federal and state, as well as our House of Representatives and our assembly people and our city council members. So I have written a letter. Anne Montgomery, who has been a guest speaker here, who is a brilliant policy analyst who wrote 4 of the bills in the Affordable Health Care Act under Obama, has generously offered to edit it for me. And she has, we won't go into this too much right now, but she has proposed a new demonstration that is 3 tiers, that she foresees a new vision for nursing home transformation. And so if enough of us can I'm kind of jumping the gun. That's going to be presented at the Unity conference that we're doing later. But my point is that we're writing the letter, and then I will be sending it. We will be sending it, Gray Panthers, to all of you. And we just ask that you send it. We send it to your legislators, and just stay tuned for that letter. Thank you.
Thanks, Rachel. Marjorie, you want to ask your question?
Yes, I want to thank you, Irving and Michael. I so appreciate your information and everything. I'm a big advocate here in Illinois, and what I see, how can we change the system from being evidence-based, results-based, to turn it to be a person, not a product. I'm a product. Here's the evidence based on me and everything. And I think we might be able to make some changes that way. And I don't know if you're seeing that too. And I know, Michael, as you talk, how medicine is changing more to a product based than a person based. Thank you so much.
You know, Marjorie, those are great questions. And number one, we can start with how the National Institute of Health and National Institute on Aging funds research. Do you know how many brand new medications are approved by the FDA every year that haven't been studied in older adults? So it's kind of funny because everyone talks about evidence-based, but we don't have a lot of evidence. And in order to get evidence, we actually want the kind of evidence Irving was talking about. We want to develop better metrics for quality of life and what quality of life means to older adults and their families. So we really, but the problem is there are huge special interests that do not want to see this, because I have discontinued more prescription drugs in my career than I've started. So imagine if all doctors practiced the way I did, the pharmaceutical industry would be decimated. And they don't want that. So that's the last thing I want to comment on. The one thing this pandemic has taught me, I may have my idealistic goals, but we need to figure out what we can actually implement and change. And I think that's a real tough question.
So that's really at the heart of Marjorie's question. Is what's possible within the system. And my personal perspective is that aside from putting lipstick on the pig, there's really nothing you can do. The system is at the effect of the way the money is parsed out. It's at the effect of politics which currently is not concerned with policies, but only with scapegoating. And it's in profound denial. I think that the real issue with the political will is that most politicians don't care. It's just a pimple on a duck's butt. It's less than 46% of the total of the average of what OECD spends. That Zuckerberg spends more lobbying than the federal government spends caring for persons of age. Just so what can we do about that? I think Mike's absolutely right. There needs to be more education. I disagree about some of the things he's saying about pharmaceuticals. Makes a good soundbite, but I really don't think it's true. I think that if you looked at the budget for Viagra, it would be way, way more than the budget for psychotropics in nursing homes. And it's it's an extraordinary statement that he's discontinued more medicines than he's started. And that's wonderful. But the real problem is that psychotropics are used as chemical restraints because I choose those words carefully. We put persons with those disabilities into buildings because we don't want to deal with them. That's denial.
Well, and also Irving, if I might just, I'm Rachel here. I hope it's okay if I jump in, but in the Nursing Home Reform Act of 1987, there is actual verbiage, wording that says restraints, chemical restraints should not
That's
be used, especially people with dementia,
That's exactly right. Ruth.
right? The
Yes,
staff
and the-
should use non-pharmaceutical means to
Yes.
engage with people, but this is also an ageist issue. And, you know, it is a lack of humanity and compassion, because people with dementia need to be talked to in different ways and treated with different respects, because they do not have their language anymore very often. They are unable to speak for themselves. And so we're actually,
all of that's true.
so how do
all-
we,
all that's-
how do we hold these people accountable to keep the law going?
I don't believe if I may, I don't believe that we hold anyone accountable, quote unquote. I think that's scapegoatism. I think if you want to look, going back to what Michael said, if you want to look at the root cause of this problem, that is to say, the use of chemical restraints in congregate care centers in the United States. If you want to look at the root cause, it's our approach to the care, support, and treatment of persons with those conditions. And that treatment is driven by money, politics, and denial.
Yeah, look, one of my frustrations is CMS will pat itself on the back for lowering antipsychotic use, but antipsychotic use is still at least 3 times higher than it ought to be. There are specific, look, in an average nursing home, there are probably up to 3% of residents who might benefit. And again, these are folks who are having ongoing, true, dangerous psychoses, delusions, things like that. But we all know that the antipsychotics are not used for that. They're used for so many other things. And, which is why some of my colleagues focus on the 3%, and I respect that. I focus on the 15% because to me, it's a travesty when medications are inappropriately used. But by the way, when I've given talks in the past to nursing staff and nursing facilities, I've told them that asking for an antipsychotics is the same as asking for duct tape and a sock to put in the resident's mouth. So just so you'll know where I stand on the use of antipsychotics.
Let's see, Marcy Gitlin says, I wonder if some of what appears to be lack of care, is real deep-seated fear about aging. The prospect can be difficult to face for ourselves and those close to us. I guess that's not a question, but more.
No, it's certainly a good point. And if I may, Michelle, if any of you are at all familiar with Faulty Towers, John Cleese's comedic, serious civic commentary, that's the way people in the United States look at aging and residential care. And I do want to emphasize that money, politics, and denial, it's too easy to focus on SNFs. It's too easy to focus on skilled nursing. It's the whole process by which we care for persons of age. It's the whole process. It's not just the 2.5% or so of the age qualified population that wind up in skilled nursing. It's much more than that.
Gilbert, you have your hand raised. Would you like to speak?
Yes, I just want to clear up a point though that we've been discussing just now about antipsychotics. 25 years ago, where we had an average 8-to-1 ratio CNAs to residents, and we had a small dementia unit with specially trained CNAs and nurses, we did not use that many antipsychotics. I've seen over the years in the nursing homes how the growth has gone up as the number of CNAs has come down. So if I only have a 13-to-1 ratio, and I have 2 or 3 people who have dementia, I have no time to take care of them. So the doctor orders a psychotic drug. Why? Because then I become an idiot and I just sit in the wheelchair and I don't make trouble for anybody. So it's been the use of antipsychotics to make up for the number of CNAs that I have. Why? Because the less CNAs I have, the less money I spend. I mean, it's that simple. And again, it goes back to money and accountability and transparency. We don't know where the money is going. And some of the private equity companies created this whole issue of real estate, where I remember 25 years ago, if you had a nursing home, the real estate belonged to you. You didn't have to pay rent. All of a sudden, somebody got wise and said, oh, wow, I can strip the real estate and sell it to the market, make a lot of billions of dollars. And guess what? I can charge rent. And then all of a sudden, the whole issue of taking care of a human being has become a business. So everybody wants to go into the business because you can make money. Even though we spend less money taking care of all the people, there's money to be made. Why? Because private corporations are going into the business. I remember 25 years ago.
Let me reflect on that, Gilbert, because I've been at this now for 40 years. And I do have a very clear recollection across the United States of the trajectory of the sector. And the ratios you used, you must be in New York. You must be referring to New York, because there's no other place in the country that had ratios of 8-to-1. Fast forward to 2023. Demographically, there isn't enough supply to create ratios of 8-to-1. There simply isn't enough. So that points to a deeper problem. But here's what I would like, and I'm going to say this in as loving a way as possible. Please don't take that message forward as your advocacy position, because I promise you it will fail. That's scapegoating. And if you can't go to a public policy forum with a real policy, stay in Zoom calls and share.
I want to double down on what Irving's saying, and it's hard. And I can't tell you, I admonish folks when they tell me that there's a difficult patient or a difficult family member. Over the last 3 years, with over 200,000 deaths in nursing homes, families are pissed, and they have every right to be. However, and this is what being angry and lashing out doesn't end up accomplishing things. And I think that's where Irving's point, I think we have to strategize on how to bring about effective change and channel that anger in positive ways. And look, with that said, everyone who's angry has every right to be. Okay, I've been angry. I've been pissed. I mean, but we have a very complex, I've been watching reruns of The West Wing, and it reminds me how complex getting things done in government is. And we have to realize the federal government is responsible for the vast amount of payment to nursing homes. And so if you don't understand how the federal government works, how the legislature works, how the White House works, just saying you want something isn't going to make it happen. So it really is a lot of strategic stuff. I love the comments here in terms of working with the senators and stuff. And Carrie wants to jump in. Go ahead, Carrie.
So where you said, Mike, we are pissed, and the facilities, want to say that the family is the problem. I've used the pandemic to prove that we can change that. The facility my son is in 5 years ago would have told you I was the problem. Today, they will tell you I'm the answer. And they went as far as actually giving me an award for advocacy to make people realize that the family is not always the issue. So if we do it the right way, which is what we're working on between things like Transformation Tuesday and trying to work with our legislators and working with people like Mike and everyone else, we will eventually make some change. It unfortunately is slow, and I've been very quiet about this whole award thing, but what you just said, we can prove that you can change this, because I just did it, and I don't know exactly how, but it worked.
Michelle and Jack, can I just say one quick thing?
Please, go ahead.
Michael and Irving, thank you. And Carrie, thank you for what you just said, because I know that it is so overwhelming and it is opening up Pandora's box when we get on one of these calls. And everybody is here because they either work in this industry or have loved someone in this nursing home world, or I see in this very call today, nursing home residents that are with us, that are listening to our words. And we have more power than we think. And I know it gets overwhelming, and I sometimes go to bed and I feel so overwhelmed, but then we wake up the next day. And Carrie, thank you for the work you do. I'm so proud that you got that award. And I just want to say to Michael and Irving, we're reaching out to the heavy hitters, the big senators, the federal people. Would you advise that we reach out more to state government officials more, because there is more hope in the state government sector?
So you know what we passed a few bills here in California. Number one, we had a bill passed requiring full-time infection preventionists. We passed a bill regarding nursing home transparency. We passed a bill requiring nursing home medical directors to be certified. And I say that because I have so many people say, but yeah, most medical directors aren't any good. Well, yeah, that's the point. They haven't gone through the training. They don't know they don't have the tools. So California now is requiring their medical directors to be certified. So I even had someone in the federal government this last week say to me, maybe you want to focus on the states because you're going to have a better chance of getting some of these things done. And I think we got to do both at the same time, but I do think there are state opportunities there, and we can pattern them after some of the things that some of the other states have done.
If I could jump in real quick.
Go ahead, please.
We got our bill passed in Illinois, a small group of over 55 women on securing more rights for people in Illinois in long-term care, which included water as needed, bathroom things taken care of, and posting emergency numbers not behind a plant, somewhere people can see them. We had the National Health Council and the National Council of Nursing Homes come after us to stop us and say, you can't do that. It's going to cost us money giving these people water and getting them to the bathroom and posting signs where they can call people for help. But we persevered and it passed. So
there's another hand up. Sorry, is that it, Marjorie?
That's amazing, Marjorie. That's amazing.
So sorry, but Sharon Lockhart has her hand up.
Yes, I'm visually impaired, so I can't keep track of what's going on in the chat room. But I just posted about a case that was heard on Election Day, November 8th, before the Supreme Court. Halvesky versus an Indiana nursing home, which is it's just awful. They drugged a dementia patient. They moved him without the family knowing. And I think that a lot is going to rest on this outcome of this case. I'm a novice. I don't know what's going on. I just have a cousin that spent 15 months in extremely horrible long-term care conditions at a terribly high price, and now have her in independent living. But Talveski versus somebody, and it's an Indiana, and it seems to be kind of incestuous that it might be owned by the state, or somehow the state's involved in it. If you're all interested in following that, because I think the outcome of it is supposed to be possibly horrendous. Thank you. That's all.
Thank you,
You're
Sharon.
not a novice, Sharon. You are spot on. These are great concerns.
Well, we're around 3 o'clock. Does anyone have any last questions here? We're running late. Karen, is that you? Would you like to say something? Oh, no. Okay. Well, it's been another amazing and productive hour. We appreciate everyone being here, especially Michael Wasserman and Irving Stackpole. We'll meet again next month, March 28th at 2 o'clock. Evie Kugelman will be helping us with the panel. So thank you, everybody, and stay tuned for a letter that we're going to provide for you to send to your elected officials. Thank you and good afternoon.
Michelle?
Yeah,
May I
please.
ask one-
Go ahead, Melody.
In the
Last
chat,
word.
in addition to the letters we're sending out, we've, heard a lot about contacting Congress and so forth. I put a link in the chat called, it's called Crossweb. And in there, you can get a directory of who the key staff are for your representatives. And I'm putting in the chat now the mail format. So, or the email format. So
Crossweb.
once you can look up the team that works with your congressperson. You may not get the email, although you can probably figure it out, the email for your congressperson. But if you find the say their healthcare support and so forth, it shows their first and their last name. So the email, like for you, Michelle, would be michelle.arnott at I don't know where did I put it, at house.gov. Right. So
Okay.
that's another layer in addition to making the phone calls. And I believe that the Essential Caregivers Movement team has been using that successfully to be able to get in touch with Congress. So if that's helpful, it's the Crossweb, and then there's the little formula for the names of the staff.
That's great. We'll put it in our newsletter and on our website. Really appreciate it, Melody. That was very important. Thank you. All right, everybody. So let's keep on going on. See you next time.
Thank
Have a
you
good
very
day.
much, everybody. Happy birthday, Jack, again. Bye.
Thank you.
Thank you all.
Bye-bye.
Take care, everyone. Again, happy birthday, Jack.
Thank you, loves.